Hello, providers. My name is Heather Raley, and I'm a licensed counselor that works as a senior behavioral health consultant with Mosaic Group. We are based out of Towson, Maryland, and have been working with the Luminis Doctors Community Medical Center staff for the last 3 months or so in order to plan and implement the Reverse the Cycle program that's coming to your emergency department. We are very excited about this. I want to thank your staff for their involvement and advocacy for this program. I'll be talking today about what that program includes and how the provider role is an integral role within this process. So the objectives for today are to understand and recognize the purpose of Reverse the Cycle or RTC, understand the implementation at Luminis Doctors, understand the interpretation of the screening tools, understanding the role of the peer recovery coaches, and explaining the hospital-based MAT initiation protocol. So a little bit of background information. This is a grant-funded program, and we want to give you some context as to why this grant has come to Luminis Doctors. Looking at 2019 numbers, overall substance use, we've seen an increase year after year. While we don't have the final numbers for substance use in general for 2020, all evidence does support that numbers have significantly increased, in part due to the epidemic, but other reasons as well. In 2019, there were approximately 21.6 million Americans who needed substance use treatment, and unfortunately, only 2.6 or 12% of those Americans actually received treatment. A major goal of Reverse the Cycle is to lessen that gap between those who are in need of substance use treatment and those who actually receive substance use treatment. Additionally, drug overdose is the #1 cause of injury-related deaths in the United States. Looking specifically at Maryland data, we do have 2020 information, and you can see over here to the right the difference and the increase from 2019 to 2020 quarter after quarter. This specific chart is looking at intoxication fatalities from all substances. And as you see, the number has steadily increased over time. And in 2018 to 2019, we actually saw a slight decrease for the first time in several years. Unfortunately, 2020 saw a significant increase in numbers across all quarters for overdose deaths. Looking specifically at opiate-related overdose deaths, we again saw a significant increase by almost 400 individuals in the state of Maryland in 2020. We see the effects of quarantine, of COVID really start to hit in Q2 and then significantly increase in Q3 and Q4. This primarily is due to the introduction that began in 2015 to 2016 of fentanyl into street opiates. Unfortunately, we are not only seeing fentanyl introduced in opiates, but also in several other substances that could be purchased off the street, including marijuana. And so these opiate-related deaths are not limited to just individuals who are opiate using, but rather individuals who are purchasing really anything from the street. Breaking it down by region, we notice an increase across all regions of Maryland, but I'll focus today on the capital region. And so the capital region, which includes Frederick, Montgomery, and Prince George's County, saw a 32% increase in overdose deaths in 2020 compared to 2019. Looking specifically at Prince George's County, which is the reasoning behind this program coming to your hospital center. Prince George's County alone saw a 55% increase in opiate overdoses in 2020 compared to 2019. So this program is brought to you by funding from the Prince George's County Health Department as part of the SOAR grant, or the State Opiate Response Grant. And so I'll explain Reverse the Cycle. And while it's not limited to opiate use patients or curbing the opiate epidemic, it looks across all substances and harm reduction methods and assisting patients to get into substance use treatment across all substances. But this is the reasoning for the funding for this program, or the drive, I should say, is the increase in these opiate overdose numbers. What do we do? One thing that we do is reverse the cycle implementation in a number of hospitals. Now, you are the 4th hospital center in Prince George's County that is implementing this program. We went live with this program at Prince George's Hospital Center in 2019, and then at the Laurel and Bowie Emergency Departments in 2020. So all of the Capital Region University of Maryland sites have integrated and maintained their reverse the cycle program. We're very excited to bring it to Luminis Doctors Community Medical Center. And we are also bringing this program to Fort Washington Adventist within the next couple of months. There are 3 components to reverse the cycle that include universal screening and peer intervention. A peer recovery coach, and I'll explain the role of those in a bit, but a peer recovery coach who specifically works with our highest risk population. So overdose survivors and other high utilization or patients who come in intoxicated. And then MAT initiation in the ED, which we'll discuss. So how is it implemented at your hospital? The peer recovery coach model integrates peer recovery coaches who are people in long-term recovery themselves into the emergency department as part of Luminis staff to deliver brief interventions and referral to treatment when appropriate. And so the individuals, 2 of your coaches have already been hired, and they are Luminis staff. They are not contractors, and they will be working within the emergency department. We aim to hire 1 more peer recovery coach and a community-based coach as well. But all patients will be universally screened as part of the emergency department admissions process for substance use. The EPIC system will alert the peer recovery coach when a patient screens positively. And then the peer recovery coach will provide or deliver a brief intervention, which is really a discussion with the patient to understand what type of change this patient is interested in. The peer recovery coach will then work to develop this plan and then schedule any necessary appointments, including substance use treatment appointments. And so, as I mentioned, we are aiming to hire full-time staff within the ED, 3 emergency department-based peers and 1 community-based peers. But to start, when we kick off on Thursday, August 5th, we will be working with 2 total coaches in the emergency department. The hours, which are subject to change, are Monday through Thursday. There will be a coach in the emergency department between 8:30 a.m. and 12 midnight. And then on Fridays, Saturdays, and Sundays, 2 p.m. to 10:30 p.m. We tried to capture the busiest days and the busiest hours of the emergency department to ensure that coaches are on staff at those times. All emergency department patients ages 18 and above will have screening questions completed. They're located in the ED physical assessment and will be asked by the nurse. And the providers can also alert the peer recovery coach in EPIC as a provider request, which I'll show you if perhaps there's an adolescent who was not screened or a patient who was screened but did not flag positively. Providers will have the option to request the peer recovery coach to see that patient. But rest assured that this program, these screening questions, these brief interventions with the peer coaches will not delay discharge. The patient will not be asked to stay until a peer recovery coach can see the patient. So if there's a coach that's not on duty and needs to see a peer recovery coach, that coach can follow up with the patient after discharge. And so just so you're familiar, within the intake, there's now an expert screening tool. This expert screening tool starts with exclusion criteria. So if a patient is intoxicated or a suspected or known overdose, the questions do not need to be asked. We know that this is somebody that the coach should see. So the nurse should not proceed with asking the questions, but instead just selecting the appropriate response. If there are no exclusion criteria, which will be most of the time, the nurse selects none. And then we'll start being asked the alcohol questions. If a patient does not drink at all, the nurse will select never and the screen will be over. If they answer anything other than never, the 2 additional screening questions will be asked. This is called the RTC, or the Alcohol Use Disorders Identification Test, and the scores range from a 0 through 12. A score of 7 or above is considered a positive score and will be relayed to the peer recovery coach or triggered to the peer recovery coach. In addition to alcohol questions, there are 2 specific drug questions asking about illicit substance use, including non-prescription marijuana, cocaine, heroin, etc. And in the last 12 months, using any prescribed medications for non-medical purposes, such as those that are listed. So all positive patients include suspected or known overdoses, opiate or non-opiate, intoxication patients, a provider request, an RTC or alcohol score of A7 or above, or a yes to one or both of the drug questions. Peer recovery coaches will aim, if on duty, to see the patient within an hour. Additionally, I noted before that the providers have the ability within their scoring tools to alert a peer recovery coach by this expert PRC request. So this might be for patients who are under the age of 18 who you feel should interact with the peer recovery coach, or a patient who initially screened negatively or was not screened at all and you feel should see the peer recovery coach. The second arm is our OSAP program, or our Overdose Survivors Outreach Program. Like I mentioned before, this is really limited to our highest risk patients, and we have one coach that is dedicated to working with them in the community. And so the patient following an overdose, and we've actually expanded that definition for an OSAP patient at Luminis, where it's not restricted to overdose patients, but also patients who come in intoxicated as well. And the peer recovery coach will aim to connect with that patient within 24 hours and work with them to obtain any resources that could be beneficial and helpful in preventing a future overdose or a more serious concern down the line. Finally, the MAT initiation in the ED, or our fast track referral program. And so the goal is to identify patients who are opiate dependent and motivated for treatment. The peer recovery coach will work with this patient and then relay to the provider that this patient is a candidate for MAT initiation. The patient will be assessed by the provider. And if the patient meets the inclusion criteria and does not meet any of the exclusion criteria, the COWS, or the clinical opiate withdrawal scale, will be ordered for the nurse to complete. And eventually the patient will receive an 8 milligram dose of buprenorphine, which is something that we are currently working to update and should be in effect within the next month or so. And then that patient will be fast tracked, or meaning have an appointment within 24 to 48 hours with a community-based Suboxone program. And so 2 items I want to bring your attention to that you may be familiar with. One is the 3-day rule for Suboxone administration. And so providers within an emergency department do not need to be waivered per the DEA for Suboxone administration in order to alleviate immediate withdrawal symptoms. And so providers are able to administer up to 3 doses within a 72-hour period. Most of the time, our providers only need to administer 1 dose, and that patient has an appointment within 24 to 48 hours for their subsequent doses at a community-based program. However, in April of 2021, there is now not the requirement for providers to have to complete the 8-hour training, but instead, physicians may submit a notice of intent to prescribe Suboxone, and you don't need to complete this training. This is game changing, and this really opens up a lot of doors for our patients, I think. And so I know that some information has been sent out for the notice of intent, but we really encourage all providers to consider doing this because it will help patients bridge that gap until they can attend their medication-assisted treatment appointment. One of the barriers we've noticed in Prince George's County is the limited number of not only inpatient beds, but also medication-assisted treatment facilities. And so allowing an extra day or 2 for this patient to be able to obtain an appointment could really help a number of people initiate their recovery. So once a patient is determined by the coach to be opiate using, they will refer the patient to the MAT induction program as it's worded in EPIC. And this completes, then the provider would complete the inclusion and exclusion criteria within a workup activity as are noted here. If the score is an 8 or above, this will trigger, if the patient meets the inclusion criteria and does not meet any of the exclusion criteria, this will trigger a BPA for the nurse to complete the COWS, or the clinical opiate withdrawal scale, that includes the criteria that are listed here. A score of 8 or above on the COWS makes a patient eligible to receive buprenorphine. If the patient scores below an 8, the assessment is to be repeated every 30 to 45 minutes, and the nurses will receive a BPA. From the provider view, this is what it looks like. You will receive a notification that the nurse will be alerted to complete the COWS upon completion of the inclusion-exclusion criteria. The COWS in EPIC looks like this. It's a very straightforward assessment that is automatically scored. And these are the nursing BPAs that will be received. Initially, there will be a BPA to complete the COWS assessment, Following that, if the score is not an 8 or above, there will be a second or subsequent BPA to repeat the COWS assessment. We are working to obtain the 8 milligram buprenorphine and naloxone medication within your pharmacy. As of right now, I believe the AAMC Luminis protocol requires smaller doses initially, perhaps a 2 milligram, then 4, then 6 milligram. We're actually working for it to be universal across sites, and specifically at Luminis doctors, that when a patient scores an 8 or above on the COWS, they'll be administered an 8 milligram dose. So this was discussed, I believe, at the most recent local PNT committee meeting, and we are pending approval, waiting to hear if it needs to be discussed at the larger PNT meeting, but more information to come on that. However, we are moving forward with this time with the current MAT initiation protocol, allowing patients to be dosed with the lower dose of Suboxone within the ED. So the buprenorphine education, as you may be familiar with, the sublingual tablet or pill is to dissolve under the mouth and under the tongue, and we are educating nurses on this as well, as they may not be familiar with it. But in summary, the Reverse the Cycle program includes 3 components: the Universal Screening and Peer Recovery Coach intervention, the overdose specific coach, and the MAT initiation. As noted, we have not hired an OSAP coach at this time, but we do expect somebody to start within the next month or so. The providers initiate the buprenorphine induction program by completing the inclusion-exclusion checklist, and this will automatically trigger the COWS assessment to be complete by the nursing staff. And peer recovery coaches are full-time staff within the hospital. They are Luminis doctors staff, and they will be working, as of now, 8:30 a.m. to midnight on Monday through Thursday, and then Friday, Saturday, Sunday, 2 to 10:30. I want to thank Dr. Marshall and Dr. Girodaghi, who have been integral in bringing this program and the planning process from the provider point of view. You may see them with any questions. My contact information, Heather Raley, is located here, my email address and phone number. Additionally, your peer recovery coaches have been hired and are currently in training, so you may see them in and out of the ED. There are 2 wonderful ladies in long-term recovery named Kimmy and Virginia, and I look forward to introducing them to your entire staff. Please feel free to reach out with any questions at all, and I want to thank you so much for your time.